Good morning, chairs, ladies and gentlemen. Thank you for the opportunity. Let me present our study, which is, does stereoscopic vision accelerate laparoscopic skills acquisition in comparison to conventional laparoscopy, a randomized controlled trial? How can we do better in minimally invasive surgery? I could operate with one eye. I could operate with two eyes. But which is better? And from literature, stereoscopic vision in laparoscopy gives more image information with higher resolution, brightness, and sharpness of colors, facilitating depth perception. However, it comes with some disadvantages and limitations, such as feeling headache, eye strain, and nausea. Glasses, which are essential to appreciate 3D picture, give even more strain. The setting is expensive, and 1/3 of people do have problem seeing the displayed depth perception. In this study, we aimed to evaluate the effect of 3D versus 2D imaging in the performance of laparoscopic skills in novices and face validity of the passive 3D laparoscopy. We did a randomized prospective study in which we recruited 56 students who were randomized into two groups, 2D and 3D. The training curriculum they did is the fundamentals of laparoscopic surgery, which is a validated curriculum by the American College of Surgeons. It involved big transfer task, endoloop, extracorporeal suturing, and intracorporeal suturing. This is the study protocol we followed. We started with 56 candidates. All of them, they did the pre-study questionnaire to eliminate any subject with uncorrected visual problem, color blindness, and so. They had induction to the curriculum by oral presentation and video demonstration. And then they underwent block randomization blindly into two groups, 28 in each group. We did eliminate 2 candidates from the 3D group because they failed the adaptation exercise. And then we ended up having 25 in each group who completed all the 4 tasks. They did the post-study questionnaire, and in total, we analyzed 50. And this is our lab in Barts. This is the 2D setting. We used a 16-inch screen at a distance of 120 centimeters from the candidate. And this is the 3D setting. We use 32-inch screen at a distance of 260 centimeters from the candidate. All 3D participants underwent an adaptation exercise to make sure they can visualize the 3D picture. This exercise was purely ocular and doesn't carry any manual practice to make sure it won't affect the learning curve. Performance was evaluated according to performance time, number of repetitions, and errors. Those are the 4 tasks we used, and all the tasks carry a preset proficiency criteria. For example, the big transfer task allowable errors was no drop outside the field of view, and proficiency time of 48 seconds in 2 consecutive repetitions, and every task has to be done within 80 attempts. If the candidate reached the proficiency in 80 attempts, they move to the next task. If the candidates didn't reach the proficiency and they consumed all the 80 attempts, they still move to the next task, and so on. Those are our results. In analyzing candidate demographics, we found that there is really no significant difference between both the groups, almost equal male and females, and the age range as well was almost the same. All the candidates were right-handed, apart from 2 candidates in the 2D group who were left-handed. In analyzing the performance time, we found that in the first task, big transfer task, the 3D group took longer time to perform the task than the 2D group, and this was statistically significant. But in endoloop and suturing exercise, the 3D group were faster than the 2D group. And in analyzing the number of repetitions, the 3D group in big transfer task consumed all the 80 attempts. But the 2D group, they consumed less number of attempts. And this was significant. In the loop, there were no difference between the two groups. And in extracorporeal and intracorporeal suturing, the 3D group did significantly better than the 2D group. In error score, we found that the 3D group did significantly better in 3 out of 4 tasks, and this is evident by the p-value. And then we analyzed the overall performance of all the 4 tasks in total, and we found that there is no difference in performance time between the 2 groups in completion of the curriculum. And in number of repetition, we found that the 3D group performed significantly less number of repetition as compared to the 2D group. And errors, again, the 3D group performed less number of errors as compared to the 2D group. In the post-study questionnaire that our candidates did fill, we found that around 60% of the candidates reported significant tiredness, and 20% reported headache and eye strain. So from our findings, we find that the 3D give fewer repetitions, lower error score, but there is no difference in performance time in comparison to the 2D. And why we think is that? Maybe it's because of the adaptation exercise the candidate need every time they move out of the screen or they blink. And when they come back, they need to adapt. And maybe there is a flat platform in the box trainer which allow less points of references as compared to the abdominal cavity, where there are different heights and the 3D could be appreciated better. Also, we think that the static picture could give less chance to appreciate 3D than a movable picture. 2 recent studies done in this field by Smith et al. And Storrs et al., and they were done with a smaller sample size than ours. They showed that 3D reduced errors and reduced performance time. So overall, we think that the stereoscopic vision improved accuracy in laparoscopic skills in advanced tasks, and this was evident from extracorporeal and intracorporeal suturing. By reducing performance time, reducing number of repetition, and reducing errors. And in phase validity of passive polarization 3D, more than half reported significant tiredness, 1/3 reported headache and eye strain, and no nausea and dizziness reported. So the take-home message here, we think that there is a value of those findings, and we think that the stereoscopic vision could improve outcome, and by reducing errors, it could enhance patient safety.
Could you speed it up a little bit, please?
So the future of 3D technology, we think it could be overcome by the new advances in this technology. And we think that emerging glass-free 3D monitors can make it easier to adopt this technology in the future. Thank you for your attention.